seventh costal cartilage, the sixth, and this is the fifth. And this is the pubic crest, that is from the pubic symphysis to the pubic tubercle. And in this finger breadth thickness of the pubic crest, the posterior most part of the pubic crest gives the origin of narrow region of rectus abdominis, which goes upward for insertion into the fifth intercostal space, then sixth, then seventh costal cartilage. So it is narrow at the origin, but at the insertion it is broad. Rectus abdominis, called rectus sheath. The medial border of the muscle. This is the lateral border. And we have seen that the nerve supply of this muscle enters from the lateral side, T7, T8, T9, T11, 10 and 11 and T12. T12 nerve supplies the pyramidalis muscle, lies in front of the origin, is in front of the rectus. This is the pyramidalis muscle. Then in front of these two muscles is the attachment of conjoint tendon. This is the lowermost fibers of transverse abdominis from lateral 1/3 of the refracted part and from medial 2/3 internal oblique. Both combined and attached to the pubic crest. So arc fibers are there. And inferior epigastric vessels, they cross this arcuate line and they supply the rectus abdominis. Hence this hole is created, oval hole. This is called the deep inguinal ring weir. So there are three levels of section. One at the level of above the xiphoid process, at the level of T5, fifth rib, sixth and seventh. So if we cut the rectus sheath at this level, what the picture you will, because rectus abdominis muscle has crossed the xiphoid process. Xiphoid process is the property of the thorax and it is inserted over the three costal cartilages, which are the property of thorax. As this rectus abdominis will be covered by the rectus sheath, so wherever this muscle is going up and down, we have to make the carotid, this sheath. So when we cut this transverse section of the abdomen at the level of the fifth, sixth and seventh ribs, what picture you will get? The first layer is the skin. Below the skin is the superficial fascia, that is the yellow color fat. Then come the deep fascia. Because in the thorax there is a skin, soul fascia as well as deep fascia. It is only absent in the abdomen. So in the thorax you have to make all the three layers. And below the deep fascia, in the thorax also, there will be rectus abdominis muscle at all the three levels if you cut below the deep fascia. Plus, it is also covered by the aponeurosis of the external oblique muscle. Why? Because external oblique muscle take origin from outer surface of the lower 8 ribs. In the lower 8 ribs, fifth comes. Leave the first to fourth. So the muscle that is the from the outer, this is the fifth rib, the sixth, the seventh. So from their outer surface, this is the outer surface. So this muscle, external oblique, downward, forward, and median direction of the fibers. And beyond this, aponeurosis covered. So when you cut here you can make the external oblique muscle, apollinaris cannularis, the brown muscle fibers. And right meet with the left. Here is the firm decussation. That is the linea alba. So external oblique aponeurosis covers the insertion of the rectus abdominis, even in the thorax. And below this lies the muscle. That is the rectus abdominis, fifth, sixth, and seventh. And this muscle is inserting over the costal cartilage. Okay, So this is the picture you show above this xiphoid force. So here the anterior wall of the rectus sheath is only formed by the aponeurosis of the external oblique. Internal oblique. Why? Upward, forward, and so internal oblique muscle go inside the rib and it is inserted over inner. Costal cartilages of tenth, 11th and 12th rib, inner surface. So it goes below, so it can't reach up to here. So only the aponeurosis will be reached, because the internal oblique insertion is on the 10th, 11th and 12th ribs. Which part? Costal cartilages. Is the insertion of internal oblique, the uppermost fibers. which are coming from thoracolumbar fascia. So it doesn't come above the 10th rib. So the posterior wall is deficient. Only the anterior wall is having the external oblique muscle and its aponeurosis from the anterior wall of rectus abdominis. Who is forming the posterior wall? Costal cartilage of 5th, 6th and 7th ribs. So that is how you have to make this type. Then section of the abdomen above this arcuate line, anywhere, here or here, same. That we have done yesterday. First layer is the skin, then Camper's fascia, the fatty layer of abdomen, Camper's fascia, then external oblique muscle, then internal oblique, then transverse abdominis only up to linea semilunaris. Beyond this goes only the aponeurosis of the external oblique. Single and single meet in the linea. Internal oblique into two, anterior layer and posterior. Both meet to form linea alba. Transverse abdominis again one aponeurosis fused with the linea alba. The second level above the arcuate line. And here you can make rectus abdominis muscle inside the two layers. And on the posterior surface is the inferior epigastric vessels. And then here fascia transversalis. Then extraperitoneal fat. Then you can make the peritoneum. So this is how the skin, Camper's fascia, external oblique, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal fat and peritoneum. So this is the of rectus sheath above the arcuate line. So the anterior wall of the rectus sheath is formed by the aponeurosis of the external oblique and anterior layer of internal oblique. The posterior layer, posterior to the rectus abdominis, is formed by posterior layer of the internal oblique aponeurosis and aponeurosis of the transversus abdominis. And the nerve supply, it enters from the lateral side of the rectus abdominis, supplies the muscle, traverses it, comes out of its medial border, pierces the aponeurosis, and then supplies the skin of the anterior abdominal wall with small medial and large lateral branch. So that is the T7 to T11 nerves. They traverse the muscle and comes out of it. So in one diagram you can show everything. The corner, so you have to practice this. This is only to understand. You can't make it. You practice only this. Then the third level is the level below the arcuate line. So below the arcuate line is the diagram. How it is seen. It is different. Skin is having the same supply line, then the Camper's fascia, fatty layer of the abdomen. Then below the umbilicus we know at this level it lies the Scarpa's fascia also. Because scalpa fascia is only present midway between it starts from somewhere here. So here the scalpa fascia you all the three muscles are present laterally. That is the external oblique, internal oblique, transverse abdominis. With their aponeurosis of external oblique. So below the arcuate line, what we below the arcuate line there is no internal oblique muscle, no transverse abdominis muscle. So in this area no muscle is there. So whenever you take this section, so rectus abdominis anteriorly is only covered by conjoint tendon with the property of internal oblique as well as transverse abdominis. So how you show in this section? This is the aponeurosis of the internal oblique, aponeurosis of transverse, both joined to form conjoint tendon, which is fused in the midline to the linea alba. To the linea alba. Is it clear? So this is how to show by aponeurosis of the external internal oblique and transverse abdominis. They are anterior to the rectus abdominis muscle. So they are all forming the conjoint tendon and external oblique aponeurosis from the anterior wall of the rectus sheath below the arcuate line, and posterior wall is absent or posterior wall is deficient below the arcuate line, because all the aponeurosis they have come anteriorly or in the forward part. Then the rectus abdominis muscle, when it is also absent, so where the muscle is resting? On the fascia transversalis. So muscle is resting on the fascia transversalis. The rest of the muscle layer, that is the extraperitoneal fat and peritoneum, you have to make. So this is how the three levels of the rectus sheath is different in formation of the diagram. So you have to practice this, and you have to understand the meaning of these three diagrams, why they are different, why there is a difference between them. This tells you the part of it. So after doing the rectus sheath formation in all these parts, so see, the rectus abdominis muscle is narrow below, and as we are going up, it is going away from the midline and inserted over the 5th, 6th and 7th costocartilage, and pyramidal lies in front of it, meaning thereby strengthening the anterior abdominal wall. Now comes the last part of the anterior abdominal wall, that is called the applied anatomy related to it. In the applied anatomy, the main interest of the surgeon of the anterior abdominal wall is the operations done on the abdominal organs. And when we cut the abdomen, the procedure is called laparotomy. Lepra means abdomen. Otomy means to make a hole in it. So whenever we have to remove the gallbladder, or when we want to remove any abdominal organ, for example the appendix or any other structure, we have to cut the 9 layers of the abdomen, then only we can touch any viscera. So we have to remove one by one all the layers we have done: the skin, the solar fascia, external oblique, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal fat. Then we have to cut finally the peritoneum, then only we can enter into the abdominal cavity, or we can touch any organ. So we have to cut all these 9 layers, then only we can do what is called the any operation in the abdomen. That is called the procedure called the laparotomy. So for that we have to take the first cut is skin. So they are called the skin incisions. So this applied is both common for the rectal sheath or in the anterior abdominal wall. So skin incisions are made, then ultimately the other layers are also cut. Now the skin incision made, they are, one is called the midline incision. So midline incisions above the umbilicus, they are not safe, but below the umbilicus they are safe. Why? Because when we cut the skin and the linea alba above the umbilicus, we can go into the abdomen by cutting the linea alba, all the aponeurosis, fascia transversalis, extraperitoneal fat, peritoneum, we reach abdomen. It is easy way. And after doing the operation, we stitch one by one. First the peritoneum, then all the aponeurosis, or stitch the linea alba, we stitch. Then we stitch the skin. But as I already told you that linea alba is called the white line of the abdomen. White line means it is, so healing is very, very, very poor. So after the operation, there are chances that these stitches may not join the two edges of the cut edges of the linea alba, resulting after a few months of the operation there is a gap, or there is a split in the stitching area. So there is a gap in the linea alba, so any organ in the abdomen can come out. That is called incisional hernia. So patient will come with the post-operative incisional hernia, are very, very common if the midline incision are given above the umbilicus. But sometimes we have to give. So they are risky because of the hernias, but we have to give sometime only in the emergency. Emergency means when patient is dying, we have got no time to wait, we have to take the risk. Other operations, they are called electives. One is the emergency operation, other is called the elective operations. Elective operations are the operation in which we have got a sufficient time to sit and think about the surgery of the patient. Sufficient time. Then we not given the midline incision. Then we prefer the paramedian incisions. Paramedian. But before going into the paramedial incision, we will clear why the incisions are safer below the umbilicus. Rectus abdominis. You see, the medial border of the rectus abdominis is very, very near the linea alba, below the umbilicus, or it is almost overlapping. The medial border of the two recti overlaps the linea alba below the umbilicus. So there are no chances of the post-operatively incisional hernias, because the muscle is protecting the linea alba below the umbilicus. So we can give electively as well as in emergency midline incisions in the below the umbilicus. They are safe. Most common it is in the female. We do the caesarean section. So caesarean is done below the umbilicus, and they are 99% midline incisions or horizontal incisions sometimes. So they are safer. Otherwise, we have to give the paramedian incision above the umbilicus. And these paramedian incisions, they are of two types. One is called the muscle splitting. Muscle retracting. We paramedian means parallel to the midline. We give paramedian right side or left side. So whatever, we cut the skin, we cut the campus fascia, we cut the anterior wall of the rectus sheaths. Then we cut in the same line, vertical line paramedian, we cut the rectus abdominis muscle. Then we cut the posterior wall of the rectus sheaths. Then we cut the fascia transversalis and peritoneum, and we do the operation. We reach the abdominal cavity. Reversely, we will stitch them. Now here the drawback is that post-operatively, the nerve supply of the rectus abdominis is also cut here. So after the operation, the lateral half of the muscle is having the intact nerve supply, but the medial half of the muscle is having no nerve supply post-operatively because nerve is cut. This is called the muscle splitting operation or muscle splitting incision. So subsequently what happens post-operatively, this medial half of the rectus abdominis muscle undergo atrophy. So whenever the nerve supply of any muscle is cut, not only the blood supply, nerve supply is also important. So when the nerve supply of any muscle is cut, the muscle undergo atrophy. Muscle becomes thin and ribbon-like. So this muscle becomes ribbon-like. All the other layers, they are already ribbon-like. Muscle is also ribbon-like. So this area becomes a weak point, and it is also prone to post-operative hernias. Any abdominal organ can protrude from this weak area of the anterior abdominal wall, and this gives the trouble to the patient. So that we don't give the muscle splitting operation, only done in the emergency. In the elective operation, we use the muscle retracting operation. What is this operation? Here what we do, we cut the anterior wall of the rectus sheath, we expose the muscle, rectus abdominis, with its intact nerve supply. Now we mobilize the medial border of the rectus abdominis muscle. We put our hand below the medial border of the rectus abdominis muscle, and we retract it laterally. Very easily. This muscle can be easily retracted in the operation theatre because its medial border is quite clear. So we make the hand here and we split it like this. So we retract the muscle along with its nerve supply like this. So nerve supply remains intact. So this is called the muscle retract. Then we cut the posterior wall of the rectus sheath, transverse abdominis, and we use the abdomen. We do the operation. We again re-stitch the peritoneum, fascia transversalis. Then we again, as the muscle has been retracted, we again repose the muscle in its original anatomical position. So muscle is again becomes straight, regain its anatomical position with its nerve supply intact. So post-operatively, there is no any chances of hernia in the muscle retracting incisions, but they are only given in the elective operations when we got the sufficient time to sit and think about the surgery. So that you have to explain whenever a question of the applied anatomy related to the rectus sheath comes. Another condition related to the anterior abdominal wall is the divarication of the recti. Divarication. Of recti. Usually it is seen in the obesity. Obese people in whose belly is quite big. In these individuals, the two rectus abdominis muscles, they go away from midline because of the laxity of the anterior abdominal wall. So muscles, they go divert from each other. This is called the divarication of the recti. Due to which what happens? Linea alba is already there. So the area between the medial border of the two adjacent recti muscle is increased. And this increased area will lead to the chances of the hernia. It may be epigastric hernia, it may be umbilical hernia, it may be the hypogastric hernia. So hernia from the linea alba can come because linea alba is now exposed. Another congenital anomaly to the anterior abdominal wall is the umbilical hernia. It is usually congenital, and it is caused due to the non-union of the right and left surface ectoderm during embryological development. We know the ectoderm forms the epidermis of the skin. The mesoderm forms the dermis of the skin. So right and the left ectoderm, they meet in the midline. Ventrally is already there, so this is only the dorsal part. You see the embryo, this is the head end, the branchial arches, the umbilicus, the caudal end. So this is the dorsal surface of the embryo. So dorsal surface is already having the surface ectoderm. But ventral part, during the folding of the embryonic disc, right and left side of the ectoderm has to meet in the midline. So sometime at the level of the umbilicus, there is a non-union of the right and left surface ectoderm, and this lead to a gap, and that gap lead to what is called the umbilical hernia. So umbilicus is exposed. Even in the lower part, the urinary bladder is visible through the skin splitting. Or in some people, starting from xiphoid process to the pubic symphysis, there may be some growth of the epidermal tissue may be found in the midline in the xiphoid process to the lineal bulb. So this is because of the overriding of the right and left surface ectoderm. So this is called the dermoid cyst. So dermoid cyst is caused due to the overlapping of the either the epidermis or the dermis part of the skin in the midline of the abdominal cavity. So these are the few anomalies which are left congenitally in related to the anterior abdominal wall. So this finishes with the anterior abdominal wall.